been a minute. I don't even know. I don't have any excuses, but we're almost done. X is for Xylocaine, which is the brand name for lidocaine. And I have two places that I want to talk about lidocaine use in the emergency department. The first is for ACLS, pulseless VTAC VFib. It's been on and off the algorithm. In 2015, it's back on the algorithm as an alternative for amiodarone. It is usually used as second line. So if amiodarone doesn't work for refractory pulseless VTAC VFib, lidocaine is there. The dose is 1.5 milligrams per kilogram. It comes in a pre-filled syringe, usually in crash carts. So lidocaine, a sodium channel blocker, can be used there. It does become the drug of choice in pulseless VTAC VFib for patients that are in a cardiac arrest event because of a drug overdose. So specifically a stimulant drug overdose. So cocaine being the most common, but much less commonly a methamphetamine overdose. You would want to use lidocaine instead of amiodarone, because even though amiodarone is officially a class 3 antiarrhythmic, a potassium channel blocker, it does have some beta blocking tendencies. And so if a patient would regain ROSC or achieve ROSC, they would have unopposed alpha if you gave them amiodarone. Unopposed alpha stimulation from their cocaine. Because you've blocked beta with amiodarone, because it's a dirty drug, it works on a lot of different receptors. And so even though its primary mechanism is a potassium channel blocker, it also blocks some beta blocking. It has some beta blocking tendencies. And so if you give amiodarone in the setting of a cocaine overdose and you achieve ROSC, now you have unopposed alpha stimulation from the cocaine. And because of that, lidocaine is the drug of choice in those pulseless VTAC VFib patients. Otherwise, it's definitely second line after amiodarone. The other setting where we use lidocaine or xylocaine in the emergency department is for local, numbing local, right? So if we're gonna stitch a face, stitch a leg, stitch whatever we want. And we use it typically either lidocaine or bupivacaine, both sodium channel blockers. Both of them are going to have the same effect. Lidocaine works faster or lasts a shorter time, so it has a shorter half-life. Both of them are going to work pretty quickly as far as numbing the space, but bupivacaine lasts longer, so lidocaine has a much shorter duration of action. The other thing is you may or may not use it along with epinephrine in the formulation. Epinephrine causes the vessels there to constrict, and so wherever you've injected it, it stays there longer and makes it last longer. Places that you might want that to happen are places where you can handle the vasoconstriction. You typically don't use that whenever you're doing it in like a finger, because it can cause vasoconstriction to the point of ischemia and loss of the finger, and so we don't usually use lidocaine or bupivacaine with epi in like small spaces, fingers, toes, lips, noses, that kind of thing, because there's just not a lot of tissue there, and so we can cause local ischemia at the site. But if you're going to stitch, a shoulder, a torso, maybe the meaty part of the face, you might use lidocaine with epinephrine. Again, lidocaine is much shorter acting than bupivacaine. But that is the story. That was a lot of information. Sorry, I talked kind of fast there. That was lidocaine, brand name Xylocaine. X is for Xylocaine.